Okay, so thank you. So firstly, we want to congratulations on you on receiving the Pioneer in Surgical Endoscopy from CGIS. And as we know, the award is presented to outstanding, reputable leaders from minimally invasive surgery. So we're so excited to do this interview with you. And the first one, we would like to know that what motivated you to explore and innovate within the field of surgical endoscopy? And can you share some pivotal moments that impacted the direction of your work?
Thank you very much for the invitation, and thank you very much for the congratulations. For me, it's also a big honor because this is gift to people who've been working with this and innovate, and so I'm very honored for the award. When I did transplantation. I was doing livers and kidneys and pancreas. So I did a lot of gallbladders. Then in my honeymoon, I heard somebody was doing the gallbladder through the scope, through laparoscopy. I was in Hawaii in the honeymoon. So I called them and I said, this was going to happen in Nashville, Tennessee. So I called them, I said, I want to be in the course. It was the first course in the US. So they told me, we are full. We don't have until for a year. So I said, I don't live in the US. I live now, but I didn't live there. I was living in Colombia. So I said, I will pay. I don't do animals, doesn't matter. I just want to go and see what is all this laparoscopy. So they allowed me to go. I canceled my honeymoon. I went to Nashville, and then it becomes crazy. 3 months later, we were doing gallbladders, achalacias, and other stuff. So I've been doing everything minimal invasive. So changed my life forever. Yep.
Okay, thank you for sharing the journey and moments. It's truly inspiring, and we'll look forward to applying these lessons and continue to learn from your expertise. And we know every pioneer faces challenges. And what are most major obstacles you encountered while developing your groundbreaking techniques, and how did you overcome them?
One of the other things we did is it was much easier to travel then. It was before September 11th. So we used to carry a bag with our own instruments, our own trocars, and we went to little towns, first in Colombia, then in all the South American countries, doing cases, teaching people. And we also went to places that they have specific diseases. For example, there is a place in Colombia that there is a lot of problems with the spleen. So we did go to do splenectomies there for free. We didn't charge for that. And we were learning and we were teaching other people. And you were helping a lot of people that didn't have money to pay. So I think the impact was big for everybody. So every time we hear there is somebody who wants to be trained or needs help anywhere in the world that is not a well-developed country, we go. We go, we help them, we teach them. And SAGES has their own program that is global, that I was a chair long time ago, where SAGES have this program to go everywhere to teach people. Now they're going more to Africa than other places. But the American College, that I'm also governor of the South Florida chapter, they have their own program for global surgery. So I think the societies and the surgeons, we understand that we need to give the chances to surgeons everywhere, the same chances that we have, and to give those patients the same chances that our patients have. So we go everywhere to teach. It doesn't matter where. And it's been very good. It's very rewarding as a surgeon, as a person, to be able to do that.
Yeah, thank you. It's really rewarding, and it's also very impressive. It's clear that your perseverance and innovative problem solving were crucial in advancing the field. So then, can you share a memorable experience or story from your career that still brings a smile to you?
No, I mean, there are many stories, but I can tell you, for example, we used to do the Heller myotomy for achalacias by thoracoscopy because we start very early in the 1990s. So the chest because it was much easier to collapse the lung. So we didn't need much. One day, like when I've done already like 30 or 30 something, maybe 40 of these ones, I went to a little town and the anesthesiologists never were able to collapse the lung. So we went through the abdomen and we liked it that much that we never did that surgery again through the chest. So now we do it through the abdomen. So difficulties with instrumentations going to this little town make histories forever, you know. So we helped too. We were learning, being the pioneers too, because I mean everybody was starting to doing it, so there's not much people to ask. So it was very good. I mean, it was very nice. We learn as we teach. We learn too. So it was very good.
Okay, thanks for sharing. It's a memorable experience, absolutely, and it emphasizes the rewarding aspects of career dedicated to innovation and patient care. So with this word, recognizing your contribution to the world, what future projects or areas of research you're most excited about exploring?
There are a few things that are very interesting happening now. The first one is what we do by laparoscopy now. I think we will be able to do by endoscopy. I think luminal surgery through the mouth, through colonoscopy, robots coming for endoscopy, the chances of suturing through endoscopy, that is going to change. And laparoscopy will reduce, and the procedures will become endoscopic or hybrid, part laparoscopy, part endoscopy. And that will change also the wound healings, decrease the complications. So that's one of the sides. Second one, we've been working in magnetic anastomosis. So like Michelle does, we have another group that does the same. So we've been discussing about this. So I think if with magnets, we achieve no bleedings or no leaks in the anastomosis, or if we reduce the number close to zero, that's a big advance for surgery. Because what surgeons fear more is bleeding and leaks. So if we can prevent them or decrease them close to zero, so we are working on that. I think that will be the next step.
Okay, thank you. Okay, it's curious to hear about the new directions and innovation. It's also a direction for surgeons, researchers, and also for us publishers. And so to say to the younger surgeons, what are the most critical skills that they must develop to excel in minimally invasive and bariatric surgery, and how can they best acquire these skills?
For me, I know it's going to sound ironic, but the first skill they need to develop is listen. They don't listen anymore. You know, the young kids, they don't listen. They think they know everything, so they don't listen. So if they develop the skill of listening, then they're going to learn. But if we're talking about skill in the hands, I think in the past, they teach you when we did open surgery, they teach us first to suture, to use instrument. When laparoscopy started, because it was gallbladders, they teach us to dissect, to clip. Until other procedures arrive, then we learn to suture, because suture is one of the most difficult things in laparoscopy. So I think the skill that the youngs need to develop is suturing through laparoscopy or through endoscopy, that they can suture with any hand, with both hands, with any instrument. You know what I'm saying? So if they learn to suture, they can do anything, because that's the skill you need now for minimal invasive suturing, because the energy, the graspers, everything is being developed by corporations. But the suturing skill is going to be in us. That's why the robot has a role, because the robot facilitates the process of suturing. But if the surgeons develop the skills sincerely, since they're young, then the robot, you just use it if you want it or not. But you need to have the skills to, that's the skill I would say they need to have.
Okay, thank you. These suggestions are valuable for current and future surgeons. So, ongoing education and experience are key to mastering these techniques. And the last one question is that, as we know, you serve on editorial boards of several major surgical journals. And what do you think are the most important qualities of high-impact journals?
I think the most important is being selective in what they publish. I noticed that there's so many open journals now that anybody pay $2,000 or $1,500 and they can be published, that reduces the impact of that journal if you accept everything. But if you really have very good editorial board, you have very good reviewers, and they are strict and they make comments and suggestions to the authors how to improve the paper, then you're gonna grow. You're gonna grow as long. Of course, there are now big interest from the readers of single cases, the videos. So that's how you need to adapt to the digital area. Case presentation, complication of one patient with that video, how I solve it with this video. You know what I'm saying?
Yeah.
Even if it's one case or 5 cases, the reader is going to learn, because if you wait until half, 20 of those 1 or 50, it's going to happen 5 years or 6 years. But if you present 1 or 2 cases, how you solve it, that will help a lot to the readers. So you need to combine videos, case reports, and very good papers.
Oh, yeah. Thank you. Highly appreciate your guidance on these critical aspects and hope to incorporate these principles to our work. And that's all for this interview. And it's our great honor for us to collaborate with you previously on special issues in bariatric endoscopy. And so thank you once again for sharing invaluable insights. And